Good morning and welcome. I'm Mike Parrish, the Head of Public Affairs, Science and Sustainability at Bayer. And it's my pleasure to welcome you here all this morning. Thank you for bearing with us through a small technical challenge as we got started. But I'm really excited both for the critical topic that we're going to discuss today, as well as the fantastic panel that we have assembled. For some context, in 2022, Bayer started the Health Equity Collaboratory Series. And this was part of our commitment to improve people's lives in the communities where we and our customers live and work. The first installment, Advancing Heart Health in the Community, offered a closer look at barriers to cardiovascular health from the perspectives of those directly affected. The second session focused on advancing access to nutritious foods and included panelists from across the food value system. The third session, today, will focus on advancing equity at the intersection of hunger, health, and nutrition. Many of you will be aware that back in September, the White House held a conference exploring innovative approaches to systematically address food insecurity and improve health outcomes. As a leading life sciences company, Bayer is committed to being part of the solution to advance health equity in health and nutrition. And today, engaging in that dialogue on the front lines to continue to identify partnerships and opportunities where Bayer can join forces with others to combat hunger and health disparities. So during today's session, we'll take a few questions from our audience. To ask those questions, please write them in the chat and we'll get to them as best we can. Let me turn now to the panel that we've assembled for this discussion. We've invited three panelists to further discuss and provide examples of how their work is helping to advance health equity. Our first panelist is David Waters, CEO of Community Servings. Under David's leadership, Community Servings has evolved from a small neighborhood meals program delivering dinner to 30 people to a critical regional program providing medically tailored meals, plans to thousands of people with acute life-threatening illnesses, their dependents, and caregivers across Massachusetts. An advocate for integrating accessible, medically tailored meals into the healthcare system, David has formed partnerships with leading healthcare players and providers to better link clinical care and social services, designing some of the country's first health insurance contracts for prescription meals. Welcome to David. Tricia Barrett is Executive Director of Quality and Health Population Strategy at Bayer. She spent more than 20 years developing innovative solutions to measure and improve healthcare performance with a passion for addressing needs of underserved populations. From 2008 to 2019, she served as Vice President of Product Design and Support for NCQA, responsible for developing a growing and broad portfolio of innovative programs to evaluate and drive improvements in the quality and value of healthcare. And then finally, Matt Habash with the Mid-Ohio Food Collective, an organization that provides seamless access to food, nutrition, and health services at one location. The Mid-Ohio Food Collective is an example of a successful holistic approach in which health and nutrition education and screening are provided. Food is distributed through a free grocery store experience, and other social and vocational services are available on site. So welcome to our panel. I'm going to start by asking each of them a question, and then we will open up several questions that I will put to the entire panel. So without waiting, I'm going to jump right into the conversation, and I'm going to start with David. Can you talk about how community servings works with the NIH and your food as medicine work that you do as an organization?
Mike, thank you so much for having me. Good morning, everybody. I like to start with a story of a client that gives you a good sense of the work that we do. So my best friend had out-of-control diabetes. He managed it poorly. It led to blindness, neuropathy, kidney failure, dialysis, strokes, and heart attacks. He needed a diet that controlled for glucose, potassium, phosphorus, vitamin K, and sodium. But if I said to anybody other than a registered dietitian, could you run to the store tonight and prepare that meal, most of us would be completely flummoxed. And we have a lot of blessings in our lives, a lot of privilege, stable housing, money, literacy, the ability to self-advocate in the marketplace, et cetera. So when your doctor says change your diet, we often don't realize what a Herculean task it is. So programs like community servings have grown up around the United States that offer what are called medically tailored meals, essentially prescribing exactly the diet that someone needs to eat and providing it to them. It could be 10 meals a week or 21 meals a week. And it's a whole host of illnesses. So we at Community Servings, serving Massachusetts and Rhode Island in the United States, offer 15 different medical diets that we can multi-layer onto the same meal. So our first challenge is always preparing beautiful food that someone wants to eat that has no appetite. But the second challenge is really prescribing that meal that is exactly what they need to eat. And what we see is, improvements in A1C levels, better reaction to dialysis, better qualifications for transplants, et cetera. But the challenge is we were always considered an anti-hunger program and not a healthcare program. So we set out, with the advice of healthcare, we set out to prove an ROI. And what we did was we looked at patients we'd fed over the last 5 years, and we got access to their billing records. And we tracked what happened while we were feeding them. And what we saw was a 16% cost savings, less ambulance usage, 50% less hospitalizations, 72% reduction in referrals to skilled nursing, et cetera. And that opened us up to 21 new healthcare contracts where we're really partnering with healthcare. And that's where NIH comes in, is that once we've proven the cost, then it's about RCT studies and clinical proofs, much the way Bayer might test a drug and you might think about duration or dosage. We're doing the same with food. So we have 3 large NIH RL1 studies going. 2 are in partnership with Mass General Hospital and the University of North Carolina Medical School. And those are looking at patients with, one is with patients with HIV and diabetes, and one is with patients with diabetes. And it's providing meals and measuring outcomes over several years. And the third study is an interesting study done in partnership with the Tufts Friedman School and UMass Medical School, which is looking across 11 different payer systems where we're feeding patients and looking at the outcomes across all of those systems in Massachusetts. And we're very excited on these because we really believe both locally and nationally, that we're building the argument for reimbursement for meals through federal and state programs like Medicare and Medicaid. And with that, we want to build scale around the country such that medically tailored meals become a natural part of the healthcare system.
Thanks, David. I love that concept of medically tailored meals and even that ROI analysis that you're doing, really kind of on the cutting edge. I want to turn and invite Matt into the discussion, and in that same vein on kind of innovative models. I know you operate one in Ohio with the Mid-Ohio Food Collective, and can you talk about how what you do there is a holistic approach?
Thanks, Michael, and thanks for the invitation to be on this panel today. I think for us, I've been the CEO of this organization for 39 years. And when we started, we were a very small organization handing out food, and we hoped to go out of business. Unfortunately, that first year we gave out 3 million pounds of food, and this past year we gave out 85 million pounds of food. We're going the wrong direction fast for wanting to go out of business. But I think it's a reality of what's happened. What we also realized throughout all of that was we're not going to food bank our way out of a hunger crisis in this country, and we need to come up with different strategies. So we began a yes and really looking at what we were doing and saying, how can we build on this? The big transformation in food banking, which is really the sweet spot of food banking, is taking surplus food and getting it to people that are hungry. That's what it was founded on, and that's really the basis for it. The transformation back around 2010 was a recognition that the surplus food in this country is fresh food. And we had a unique opportunity to reposition ourselves. And at the same time, we were one of 3 food banks that did diabetes research, looking at people that were food insecure and saying, could you manage your diabetes? Well, it's a pretty easy answer. No, can't afford to buy the right foods. So we actually married those 2 concepts together into really starting to build a food as health strategy. And to say, how do we look at ourselves differently from an emergency feeder? The diabetes research taught us that, in the world of emergency food, people come 1 to 5 times a year. Probably the biggest misnomer in all of this is they come all the time. The majority of people do not come all the time. They come very infrequently. Well, if you want to give them fresh food, you got to get it to them more often. And so the diabetes research really was around getting food twice a month. About diabetic friendly foods and doing the study and the research around all of that. And we were improving A1Cs. So it really became our new DNA in terms of saying, if we could marry together the strategy of access to fresh food and coming more frequently, well, then we've stepped into healthcare. So what I like to say is 1 to 5 visits a year is emergency care, 11 to 24, really getting you twice a month is healthcare. And what David just said is real important. Somebody eventually got to pay the food prescription bill. Somebody's got to pay for that and see it as healthcare. And that's what the research, is really taught. This is about healthcare. We really are trying to bring together, which I don't think has been there for, our history, is how does healthy, nutritious food improve your health? We all think we know it, but as David just described, it can get really complicated in a hurry depending on your health conditions. So we've really started to step away from just the food bank language to, how do we do this in a more frequent, better way? One of the challenges with that for us was our customers, as we call our clients, were saying, I can't afford to shop at a food pantry. And we're like, what? And they're like, the days the pantry's open in my neighborhood are the days I work. The biggest change in our customers is most of these people work. And they're not, typical nonprofits open 9 to 5, those kind of business hours. And that doesn't necessarily work for people that are working second shift, third shift, getting regular access, or the days that some people work part-time, or the days the pantry, because the pantry is only open for so many hours a day. So we began a Mid-Ohio market strategy, which was really around giving people a grocery store experience. Let them shop for their own food, make it look like a grocery store, hours open in the evenings, on Saturdays. And we're building out that system now from the traditional system of food pantries and other emergency feeders that we've had in the past, to really say, come when you need, come as often as you need to come, pick up the fresh food that we have. We can work on all kinds of other issues, wraparound services. Some of these markets are co-located with federally qualified health centers, so we have access to the nutrition and to other wraparound services that people need to take advantage of. So it really was a stretch in a way of looking at the emergency feeding strategy differently, to make it much more customer centric. We started a Mid-Ohio kitchen, which was, Nonprofits do a lot of work, not nearly as sophisticated, in feeding as what David just described for the diets that's necessary, but really about after-school meals and making sure kids get summer feeding and those kind of things. But we took over cooking and created a restaurant where all of us could go pay for a meal. We absorbed a soup kitchen. They got to order a free meal. If you couldn't afford a meal, you volunteered and got a meal. We were also cooking for a daycare, and all of it was healthy, fresh food from scratch. And I think that was the biggest change for us, was recognizing that we could do this differently. So we want to expand that. We've got a Mid-Ohio pharmacy, which is really connecting healthcare doctors to our work and making sure that people get regular access to it. And finally, an urban farm. So we're really stretching the way we're doing our work. So it's a unique opportunity for us to take all of that collectively and really see ourselves as a food as health strategy.
No, thank you, Matt. I really like where you talked about, treating the folks that you deal with on a day-to-day basis as your customer, and really meeting your customer where they are and bringing new and innovative approaches and using technology to help address a lot of those. So thank you for that. I want to turn now and invite Tricia into the conversation. Tricia, you heard Matt and David share how they've built these programs using food as medicine. Can you lay the foundation for why access to healthy food and nutrients is critical to not only preventing disease, but to improving health outcomes during treatment? And maybe share some examples from your work.
Thank you, Mike. And I'm also thrilled to be here today, and particularly with these terrific panelists talking about real world, on the ground solutions to the problems that we are facing. I think there's no shortage of articles that you can find that identify the significant impact that proper food and nutrition can play in the health of our population, all the way from having the right food to be ready to learn as children. This impacts their economic viability as individuals as they grow. It also affects their ability to grow a healthy body, to learn the right ways of eating in the future, and to really just set that good foundation. Nutrition during pregnancy impacts the growth of the fetus and the ability of that child to enter this world in a healthy way. There's plenty of evidence also showing, and David's description of his friend and the experience that he had in being able to get to the right nutrition for his health shows how proper diet really does impact the outcomes of the individual suffering with an illness, as well as helping to prevent. There's evidence showing that poor diet and nutrition is the leading cause of preventable illnesses in this country, and that we have this tremendous problem of inaccessibility of food, of the proper foods for individuals living in rural communities or in other areas where there are food deserts, their inability to afford the proper food, and then this inability to understand what are the right foods to eat and to have them available to prepare in the proper ways that will help to improve their health outcomes. So one important initiative that Bayer has been engaged in is something called the Eco Diabetes Action Network. We know that more individuals, when it comes to the intersection of their health and the healthcare system, these individuals are getting their care from primary care providers, and in particular in those communities where there's an underserved concern, where there's an insufficient number of physicians, particularly that there's inability to access specialists. These individuals are going to rely heavily on our community healthcare centers, and they're going to seek that care from primary care instead of specialists. And so really important to improve the knowledge base, the ability of these community health centers to serve the communities that they're operating within. The Eco Diabetes Action Network that we've helped to support enables a holistic look at the individuals who are coming to these centers with diabetes, getting to them the right education about nutrition and diet. Many of these centers actually either partner with or double as food banks or other sources. They provide some amount of educational, cooking classes and the like, again, to help with getting them a diet that makes sense for them as a part of that community, one that is culturally appropriate for them, the foods that they're going to want to eat and want to feed their families as well. So an individual approaches the healthcare system with a particular condition, but they are operating within an entire family system, and that whole family needs to eat. So making sure that our food solutions are getting to the entire family, but also addressing the specific health needs of an individual at the same time. Bayer also, although I work on the pharmaceutical division, with our crop science work, we are ensuring that the foods that are being produced by our farmers are able to meet nutritional needs of people. So, kind of supercharging those foods to make sure that they are both tasty, something that people will want to eat. People don't like broccoli, maybe. I love broccoli, but, a lot of people don't like broccoli, but, we're working to make it tastier, sweeter, or, have that more pleasant appeal for people, but also, to add nutrients to them that are needed. We're also working to ensure that in this, our current environment, both with food shortages being caused by Russia's war with Ukraine, with global warming and other issues, making sure that crops are resilient, that they can be produced in the most efficient and best manner to feed the world. And then we also have our consumer health division, and in that work, we are working to make sure that individuals can gain access to food supplements, nutritional supplements that can then, ensure that the nutrition that they need, that they can't get from foods, are being provided in affordable ways through our nutritional supplements.
Thanks, Tricia. Very much appreciate that. You mentioned, diabetes and kidney disease, and it's been mentioned by several of the panelists here today. As I join you from Washington, D.C. this morning, I'm very much aware that diabetes and kidney disease are one of the largest drivers of healthcare spending, not just in the private market, but for the U.S. government as well. Which leads me to a question for the group here. So we'll transition into the group Q&A part of the discussion. And for folks joining us today, if you do have questions, please go ahead and put them in the chat, and we will get to them as best we can. My question for the panel, and I'll start with you, David, and then others please jump in as appropriate, comes back to those chronic conditions. And my question is, how are your programs using food to impact those health conditions like low birth weight, like diabetes, chronic kidney disease, and high cholesterol? How are you using food to address those chronic health conditions?
Yes, thank you. So I think usually when people think about food in the context of health or healthcare, we think of it as an upstream prevention tool. We're thinking about children and how they're learning in schools and how their bones are growing, et cetera. But food, when it comes to medically tailored meals, is really a downstream treatment regimen. So the research that I cited, the 16% cost saving, was patients who received medically tailored meals for only 3 to 6 months, and we were already seeing cost savings, and that was published in the Journal of the American Medical Association. So I think, as Bayer would recognize, the best science is so important when you're developing these diets, and that's the value of a registered dietitian nutritionist who really understands the science and can understand how to merge multiple dietary restrictions. So it's not that hard to prepare a meal for diabetes, but if you're thinking of a diabetic who's gone on to kidney failure or heart disease, understanding the multiple restrictions and the nuance of that is so important. So for community servings, we partner with other programs around the country to develop nutrition guidelines that we all follow together, and they're adapted ongoing as science develops. So I think that's really important, and understanding that you mentioned low birth weight. I think we are now starting to develop diets for high-risk pregnancies, and recognizing that on an equitable issue of poor outcomes around birth weights, et cetera, diet is so important.
Matt, anything you'd like to add to that?
Yeah, I think this is, it's kind of the new sweet spot that we're trying to figure out with healthcare. There was a follow-up meeting to that White House conference. It was, that really it was a smaller gathering. That was really when you start to see agriculture coming together with HHS, at a federal level, and realize we can partner versus they staying in their governmental silos. What I could see from HHS, they're still in the space of, it's much more clinically what can be proven to change and cost. And what we've shown is there's a modeling study out of Harrisburg that we were using along with our diabetes research. For a 1-point drop in your A1Cs, we could save Medicaid $8,000 a year. Okay, if that's the case, then if you give food banks some of those dollars to continue to provide regular access to fresh, healthy food for families, and do whatever else is necessary to teach them how to cook it healthy. As my nutritionist reminds me all the time, if we can give you fresh, healthy food, but if you go home and cook it the way that's not necessarily fresh and healthy, you can do a lot of, not necessarily have the advantages that we thought we were going to have. So for us, we're stepping into that space. We're partnering with infant mortality. There's a big infant mortality reduction program in Columbus called Celebrate One, because we've got really bad infant mortality problems. And how do we step in and partner very early in that process and making sure people get regular access to food? We're experimenting with all kinds of things, now lockers and delivery systems and ways to regularly bring the food to people who don't have access to it. But we really think the sweet spot is, we like to position ourselves now as a low-cost, high-value healthcare strategy. We are an emergency feeder, and we have an opportunity to really reduce, some of the significant costs of healthcare that we're facing in this country and have better health outcomes for people that are low income.
Can I jump in? There's been a lot of talk in the healthcare industry about social drivers or social determinants of health, food insecurity, economic insecurity, housing, all of these things all play into that. I think that this important point made by both of you about demonstrating or providing that evidence. We can kind of logically know it, but providing that evidence that there is, both the just health and community benefit, but an economic benefit to the country, to the healthcare providers, particularly those that bear some risk in the overall total cost of care. That's going to be essential to getting these things embedded in our systems, not just a special project that people can, point to and say, oh, look at this wonderful social benefit that I'm providing, but to really get it as a part of our fabric of our healthcare system that says, this is essential to health, and therefore it becomes an essential health benefit, to use the words of the Affordable Care Act. But finding ways of making that just sustainable as an investment strategy for healthcare organizations and for communities is going to be essential to its future.
I loved, thank you, Tricia. I love that your data point. I found it incredibly powerful, right? That for every 1-point drop in someone's A1C, you can save the government $8,000, right? That's the type of data that I think, makes the health challenges real, which really leads me to my next question. And so maybe I'll start with you, Matt, which is, traditionally healthcare and nutrition were thought of as separate, right? And you, with that one data point, just clearly linked the two. So how do we elevate that intersection between health and nutrition so that there's more broad awareness? How do we do that?
Well, we started, several years ago, what we call Mid-Ohio Pharmacy. There's a lot of Produce RX programs, Nutrition, Nurse RX, basically with the idea of, it came out of our research with diabetes. And it really was a case where what we learned early on in that process, doctors, even in low-income health clinics, weren't screening for food insecurity. They never asked the question. And when we asked them why, they said, because they didn't know what to do with it. I said, you do know there's a pantry right next door to your clinic, and they had no idea. I mean, that's how separated, siloed the systems are. And we've begun to say, how do we step into this differently? The advantage we have is we have a data tracking system that we built. We've now given it to Feeding America nationally, to really get, food banks connected to client data, which we can then partner with healthcare facilities and feed them back frequency of visit data. They send us back the health data in terms of the health improvements that are occurring by more frequent visits. So there's a unique opportunity to build that bridge. Tricia said something I think is real important in all this. Healthcare has gotten into social determinants of health. They realize they have to go upstream and start addressing some of these issues that cause the healthcare challenges down the road. The challenge with that is, there's a lot of companies out there that have healthcare referral platforms right now, and healthcare is paying that referral platform to make a referral to a food pantry, and the food pantry gets nothing out of that deal, except another customer, kind of thing. So somewhere along the line, as my counterpart in San Antonio says, somebody's got to pay for the food prescription. And it's a recognition that, food is a good, low cost, high value healthcare strategy. And if we can step into building that connection, and Dave, we've all talked about, what's important is proving it. You've got to prove the connection. We all take it for granted. If anything's happened recently, since COVID, is we realized how precarious our food system is, and now we're seeing with inflation that half of America is struggling to access food. So it's a unique time for us to really say, how do we use food as a real strong healthcare strategy that can prevent a lot of the costs down the road? And I think that's even David's work's doing that. I think in the sense of I'm preventing from this situation getting worse than it is that causes our healthcare system more money.
I think that's great, Matt. I think that the important thing is to meet as equals between healthcare and CBOs or NGOs. There is a egotism to healthcare that thinks that they know best. And yet, if you want to be on the ground, boots on the ground, caring for people and really addressing health equity issues, nobody knows that better than food banks and food programs and other community-based organizations. Yet there are a lot of barriers. We need to play at the level of healthcare, but there are a lot of technology barriers. Matt mentioned, each hospital system has their own EMR, their own electronic medical records, and a program like ours has to have the technology to talk to multiple systems. Well, those are very expensive. Every time we start a new contract, it costs us about $30,000 or $40,000 just in beta testing the data bridge from our system to their system. And they don't pick up that cost. So much like Matt's saying, who's paying for that prescribed meal? Who's paying for the data interventions? Is it the CBO that is driven by philanthropy or a business entity that wants to partner with us? So I think those are some of the challenges around technology, as well as HIPAA restraints. And we recognize the importance of them, so we're not minimizing those, but they are challenges for many CBOs.
Maybe a quick follow-up on that, because both Matt and David, you mentioned, data and technology and how you use it to address the challenges for the communities that you serve. What opportunities do you see that are not being currently addressed, either in gaps in data or technology solutions that would help you do the good work that your organizations do?
Well, I think from our perspective, David hit it on the head. It's the building those API connections and all those kind of things, and dealing with, you're never going to make I have 680 partners. You're not going to make them all HIPAA compliant. So when we hide behind HIPAA and those kind of things, but I think we've got ways that we can bridge the gap between the nonprofit and the healthcare. And the other challenge is really in the case of each of our customers. The digital divide in this country is real. We discovered how bad it is when everybody had to go home and go to school. during COVID and the challenges of that. And you get into rural communities, they still don't have good broadband phone service, let alone, access to the internet. So we take those things for granted, and we've really got to be continually addressing the internet access and digital literacy, how to access. More and more of this is going to, platforms and apps and everything else for people to access. And if you don't know how to do that, we're constantly reminded of that because we've got a really large senior citizen population that we serve. And you have to be mindful of that as you're stepping into new strategies. So for us, it really is, stepping into that work and realizing we have a responsibility to make sure we're addressing the needs of all of our customers, and the gap in the digital space is huge.
As a longtime quality improvement and data geek, as I often have been called, I think that an important feature here is the interoperability of the computer systems, in particular, the healthcare related ones, the EHRs and so forth, because it was already mentioned, there's very few providers out there that are systematically screening for food insecurity. And, to take it another step further, there's, food insecurity, and then there's nutrition insecurity, is another piece of the puzzle. And there is work being done to standardize the way that information is collected, so that, there can be an exchange of information. Because even if they are asking the questions, if it's not being captured in a system somewhere, in a way that the next system that interacts with that patient can pick it up and use it, and then, that they can feed it to organizations like yours to be able to then feed that patient. This is an important feature. So the federal government in policy decisions are passing regulations or other activities to measure whether or not that information is being collected and captured, importantly. And so I think that's an advance that'll help to ensure that, at least on that front end, on that action of finding out who needs what, we can start to get that information into the system.
But that's a really good point, because I asked, my doctor who started doing that in one of our health systems in Columbus, and he had a whole screener of all kinds of typical questions he would ask about safety at home, et cetera. And when it came up to food insecurity, that question came up, and then I went in and I asked him, what do you do with that? He said, we collect it. They weren't doing anything with it yet. So the question is, what does healthcare do with the data they're collecting? Because that could be a huge help to nonprofits in this space where we don't have, data analysts are very expensive, and having the all that skill set at a nonprofit is almost impossible to sustain. So that's another area where healthcare could really step up in a big way.
When we had our very first healthcare contract, Mike, we were in contact with the contract managers, but nobody in senior leadership at that health system knew that we even had a contract. And when we finally got their attention, they were so excited, and they said, wow, this is so cool. What does the data show? We're like, well, it's your data. We don't have access to it. We can only tell you how many meals we delivered and whether they were on time and things like that. But it's your data. And so again, that sense of partnership and meeting as equals, and on the technology front, making sure that the links are bidirectional. So we can receive a referral, but we can also report back to that doctor or PCP that, yes, the patient got the meal and it was a diabetic renal diet or whatever it might be. And no, they didn't get it because they've gone AWOL, or, they've fallen from the system, or they changed their insurers or things like that. That all of that data is so important.
So maybe picking up on that, because some of you talked about, obviously, some of the challenges or barriers that you face. If you had to kind of pick out one thing, what is the one systemic challenge that you face in how we address, health and nutrition equity? Again, I know we're drawing at least close to the end of time here. So maybe quickly from the three of you, if you had to pick out that one challenge, what would it be?
Well, I would say it's obviously reimbursement. It's when something as critical as what we put into our bodies, first of all, we've forgotten that impacts our health. which is so critical. Doctors aren't taught about nutrition in med school. But if we base purely on philanthropy to try and address poor diet, not only food insecurity, but poor diet, we're never really going to get ahead of the problem. There has to be, through Medicare or Medicaid and private insurers, a respect for nutrition, but also willing to invest in it, and to recognize that you have to spend money to make money, and there will be a net savings. A tough study published in JAMA came out this fall that showed that over the 10 years, if every patient in America that needed medically tailored meals, which is really just the top, 3, 4, 5% of the population, we could save $185 billion. But when we bring that to the federal government, they say, yeah, but you gotta pay for those meals. And we're like, well, the $185 billion is a net savings. But the federal government is stuck on the initial investment rather than the ultimate savings, which is just, to say it's penny wise and pound foolish is an exaggeration.
Yeah, I would agree with that. I think it clearly is the reimbursement. You cannot expect charity, philanthropy to pick up the healthcare cost of nutritional security. And that's really what this is all about at the end of the day. So for us, it really is there. Government can help. I mean, one of the things that's going to get debated again, we got the Farm Bill coming up again. You're going to have SNAP. We're about to lose the enhanced benefits of SNAP. So we're going to have seniors going from $280 a month to $23 a month here real soon. So there's a loss, at the time when we're seeing, food inflation. So really looking at, for us, it was really looking at SNAP as a good public health policy as opposed to an entitlement program we all love to hate and want to get rid of. And it's stepping into that space and realizing that we can partner to do these things. Medicaid in Ohio is bet on managed care organizations, getting people healthy. Well, if you don't pay attention to nutritional security, you don't have a whole lot of chance of getting people healthy if they don't have access to it. So for us, it's really stepping in and realizing this is a partnership, and something David said is really true. And that's, they got to look at us as equals. This isn't us holding out our begging cup as a nonprofit and you pouring a little bit of money into it. This is really about how do we partner together to have better health outcomes for people who cannot afford to do it on their own. And I think, and that on your own is a wide ranger. You can, I was on a hospital board for 9 years, and very end of it, I was leaving, at the ACA coming in, and you don't want the patient back the second time. So they had a checklist a mile long and food wasn't even on it. And I'm like, well, that's just, clearly, a testament to where you put the value of people having regular access to food as a nutrition, as a healthcare strategy.
Matt, I'll follow on something you said, and very selfishly, because I've mentioned I'm joining from Washington this morning, and you mentioned the Farm Bill, which leads me to a question, which is how can we collectively work with lawmakers, policymakers, different stakeholders to advance policies that make that connection between nutritious food on the table and diet to positive health outcomes. How do we do that?
Well, I'm going to make it real simple. The last time we negotiated the Farm Bill, I took 3 hospital CEOs and a doctor from Children's Hospital with me to lobby on the Farm Bill. It's the first time ever I've seen all of my elected officials in a meeting. Usually you get the aides. But it was really like, why are you doing this? And Senator Brown, when I said to him, we're trying to get you to understand that food stamps is SNAP is a good public health policy. And you've got to look at it that way. Fortunately for us, he's on the Ag Committee, and a few days later, he used those exact words in the Ag Committee meeting. But it really is, healthcare can drive this, but they've got to see, as David just said, they've got to see the value of nutrition. If they see that as a real, viable strategy to preventing additional costs in the system, then we can win this battle. But if we don't look at it that way, if we look at it as that little soft science over there called nutrition, then we're not going to win this battle.
Very true.
I've got our first question from the audience here, and I'll open it up to the panel, and whoever would like to jump in first, please do. And I think this touches on comments that have been made earlier, which is how do we help healthcare providers see programs like yours as a way to eliminate illness and disease? How do we help healthcare providers see that?
Well, I'll start, to me, it starts in medical school. One of my favorite comments was from the Surgeon General. I think it was in the Obama administration, and he said when he was in medical school, the only nutrition class offered was an elective at 8 a.m. on a Saturday morning. And how many of those med students were, getting up on a Saturday to go learn about nutrition? And so better weaving nutrition into med school curriculums, whether it's culinary medicine or that sort of thing, but also better understanding the role and the value of an RDN, and not thinking that medical doctors or PCPs can replace the science and the knowledge of RDNs. I'm a huge fan of that important part of healthcare that is often given, I think, short shrift.
I would 100% agree with that at Ohio State, they get one course in nutrition. I think it is offered during the regular curriculum, not on the weekend, but that's all they get. I often said, if you want to know anything about nutrition, don't ask your doctor. You better better go find a nutritionist. And, that's what it really got to build, that connectivity. Nutritionists need to be part of the healthcare team and seen as an equal partner on the healthcare side.
Yeah.
And I think, sorry, Tricia, I was just going to say,
okay,
also understanding the social determinants of what's going on in that household. Why is it that they're not eating a healthy diet? If that doctor doesn't understand the cycle of SNAP and, when they have the resources to pay for something and when they don't, and what other stressors and social determinants are going on, whether it's, rodents or unstable housing or literacy issues or fear of immigration, they're not really going to be able to help their patient. So they need someone to sort of translate almost for what's going on in the household, and that's often a CBO.
Yeah. I would also mention community health workers as another essential part of the team. If we always ask the most highly trained, most expensive individual within a practice to do all of these things, it's not going to happen. They're not equipped to do that, nor is it an efficient way to have it happen. So engaging those community health workers or individuals who may not have the direct clinical training, but have the understanding of how the community works and how to connect up with service organizations. So, they need to be invested in, you need to have them, and then you also need to be able to get the right patients or the right individuals to those resources that exist in the community, and community health workers can help to do that.
One of the things a doctor said to us, real quick in Eastern Ohio was, my patients will never tell me they don't have enough food. They'll tell me they don't have a ride. They're afraid if they tell them they don't have enough food, there'll be children's services consequences for, not taking care of their kids. So there's a real fear that sometimes that we've got to get over that with people and make, those conversations safe places and give the healthcare providers strategies for addressing those.
Thanks,
I want
Matt.
to
Go ahead,
amplify that issue of reimbursement as a problem. We need to see food, nutrition, and a number of other of these features. I mean, we haven't talked about the economic insecurity that then causes somebody to not have proper electricity or proper materials in which to use to prepare. So if they don't have a refrigerator, they don't have a reliable one, they're not going to be able to maintain those fresh foods. And so we need to recognize the social benefit, the societal benefit of nutrition and proper food access.
Thanks, Tricia. I want to put one last question to the panel before we wrap up today. Because obviously we've spent a lot of time talking about equity sitting, at that intersection of health and nutrition. And your organizations in particular, Matt and David, are doing really good work, impressive work in the communities that you serve. So my question for each of you is, what are the obstacles that are preventing programs like the ones that you run from being adopted at scale across the country? What are those barriers that you see? And maybe I'll start with David and go to Matt and Tricia next.
Sure. I would say three things that we've touched on in other contexts. One is scale. How do we offer the same service that the community servings offers here in Massachusetts and Rhode Island in all 50 states or other countries around the world, and do it with respect for the patient and respect for the food, because you can always dumb it down and provide a more processed product. But that's how we got in this problem to begin with, was highly processed foods. And so really scale, I think, is important. The second we touched on was funding. Not asking this to be borne purely by philanthropy. It's just we're never going to get ahead of this issue. And we know how expensive it is to the system overall. And then the third would be shared systems, and really looking at how healthcare and CBOs can be meet equally to solve the problem, and with respect for each one's expertise, and understand the barriers, whether it's data security or data bridges or that kind of thing.
Matt?
I look at this as, first of all, there's a lack of dedicated staff at the institutions across. I mean, we have one nutritionist who gets all of our data back in that, you know, fairly qualified health centers. And when that person has time amongst all that other person's jobs, then they would give us back information. So there isn't, you know, a lot of dedicated staff looking at this. Coordination across the states and the feds. You know, I talked about, ag and HHS coming together. You know, you got different funding levels, you know, for SNAP ending at 130 and Ohio Medicaid ends at 138% of poverty. You know, there needs to be better coordination and recognition that we can do those things differently. Clearly, the restrictions on what Medicaid continually says they can't pay for, you know, it needs to be addressed. And I think that finally, for me, the last thing is really looking at this as a long-term. We've talked all during COVID as, you know, this is a marathon, not a sprint. Unfortunately, we're running it at a sprinter's pace. But we need to look at this, you know, longitudinally, you know, and how do we begin these processes? We cannot expect, you know, I call quarterly earnings thinking, you know, this isn't going to change in 3 months. This is going to need multiple years, and we need to go on that journey together.
Yeah, I think similarly, the fragmentation in both our healthcare system and in our reimbursement systems, our payment models, our approaches to the way that we fund these social benefits is the biggest barrier that we face to see this spread. I can't really add anything more than what Matt and David have said on that subject.
Well, perhaps on that note, I want to add my sincere thanks and appreciation to David and Matt and Tricia, not just for the work that you do every day, but for taking time out of that very busy day to come and join and share your perspectives with us. You know, Bayer is in a unique position to advance equity in both health and nutrition, as we've discussed today, and we're committed to building on those efforts to make a meaningful impact. And the ideas and thoughts that you've shared with us here and those folks listening in have certainly helped to advance that. I'd encourage everyone that's been able to join us today to take a closer look at how we can shape policy, as we discussed, to build efforts that address health equity, that eliminate food security, and build a culture of wellness in the United States. And we heard some fantastic examples of the good work that's happening. I'd encourage everyone that was able to join to continue the dialogue by sharing your thoughts and comments in the chat. This will be available for replay afterwards. And again, on behalf of Bayer, my sincere thanks to the panel and for everyone for joining us today. Have a good one. Thank you.
Thank you.
Thank you.
Thank you.